Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. We are at the last Tuesday of April, so it's April 28th, which means this is Top 10 Tuesday. I'm going to try and make this the last COVID-related podcast for a while. I think that's really what we were inundated with in April, and so I had one in March because that's when it all kind of came crashing down on us. But May we'll have topics completely unrelated. If it kills me, I'm going to do that, just so you know, because I'm kind of tired of the topic myself. But today, since we do have some new codes for COVID-19 ICD-10-CM, which are our specific diagnosis codes and specific direction on how to code for this, even if the test result is unconfirmed, I wanted to do a top 10 for COVID-19 ICD-10. So this direction comes from CDC, which is the Centers of Disease Control, and the WHO on how to report and code for these encounters. Now, I want to comment up front because most of you that know me know my middle name is compliance and doing things correctly. And I do not agree with some of this direction. It's never been directed this way before. And I personally believe that it may manipulate and inflate the number of COVID cases for monetary gain. But I can only speculate about that. I can't prove it. I just think it could. So even though I am of that opinion, I still have to give you the published rules so that you are reporting it correctly. So if you need the information, as always, in PowerPoint or educational format to bring back to your physicians and your practice to teach and give the information to you, please go to my website at terryfletcher.net. And I have an on-demand webinar for COVID-19 coding. So also, if you have some kind of a download that you got from CDC that's dated February 20th, 2020, that is now dated. And you need the new published documentation that is actually dated 4/14/2020. And so make sure you get that update, and you can find it on the CDC website. But first, the Codecast podcast is also brought to you today by Murad Hydrating Water Gel, the face moisturizer that features a unique blend of 5 minerals, 5 vitamins, and 5 peptides. Helps strengthen the skin's barrier in as little as 30 minutes to prevent water loss while refreshing and smoothing skin. Murad.com. Turn on brighter skin. I have to appreciate the people at Murad Hydrating Water Gel because I mentioned it on one of my personal tidbits one time, and apparently it went viral or somebody picked it up, and they said, "Hey, can we be a sponsor?" I'm like, "Sure, yeah, that'd be great." So give them a shout out, and now they're on as a sponsor. So I really like their product. So if you get a chance to look at that, please do, because it's a great product. Okay, I guess something that's great when you're almost at 125,000 listeners. Yes, 125,000 listens. Can you believe that? I'm pretty excited about that now being in April 2020. Okay, so let's talk about the COVID-19 ICD-10 information. And it's kind of interesting because it's, again, direction that we're not used to. And we got some new codes that were effective April 1st, 2020. And remember, the ICD-10 codes become effective October 1st. So for them to throw in a code right away to make sure that it was available so that things are reported the way they want to see them for statistical information, that was unprecedented. So the fact that they recognized that in this pandemic, we need a code and a coding guidance to understand how this all works is good for them. I mean, it was interesting because when everything started coming out about the vaping, they said, okay, we're creating new codes, and they kind of made this buzz about it. And then they came up with a new code, but then said in the direction that we can't use it until October 1st, 2020, which is when the new codes for ICD-10 come out. And so the fact that they fast-tracked the COVID-19 codes was just, again, unprecedented. So we want to make sure that you do have that information. I'm starting to get a lot of questions on it now because I think a lot of practices have held back claims when it comes to COVID, just making sure they're doing it correctly. So here is the top 10, and I'm going to just pick out from the official guidelines things that I feel that should be on the front line as far as being reported, and then we'll go through, or I should say, then you can go through and find the information, and then you'll see that there's more than 10 topics. But because it's Talk 10 Tuesday, I wanted to give you the top 10 that I felt was important. So number 1, code only confirmed cases, but here's what they say about confirmed cases. And this is where my radar goes up as, okay, this is a problem, only because of the definition that you're going to hear from what is a confirmed case. So it says code only a confirmed diagnosis of the 2019 novel coronavirus disease. That's why it's called COVID-19, because that's when it first became apparent, was in 2019. It says, as documented by the provider, documentation of a positive COVID-19 test, or, doesn't say and, or a presumptive positive COVID-19 test result. For a confirmed diagnosis, assign code U07.1 COVID-19. So this is an exception to the hospital inpatient guidelines. The AHA has something in section 2H that requires a test. So in this context, confirmation does not require a test, or documentation of the test, I should say. Its provider judgment seems to be sufficient enough if the doctor says they probably had it. It says presumptive positives, COVID-19 test should be coded as confirmed. I have a hard time with that, but I have to give you the published rules. It says a presumptive positive test result means an individual has tested positive for the virus at a local or state level, but it's not been confirmed yet from the CDC. And apparently that's no longer required. So if the provider documents suspected, possible, probable, or inconclusive, then they're saying do not code that as U07.1, but assign a code explaining the reason for the encounter. So it could be they came in for a fever, or let's say that they had contact with an suspected exposure to someone who had COVID. Then that would be a Z as in zebra 20.828, and that's contact with and suspected exposure to other viral communicable diseases. So that's kind of an interesting direction. Number 2, sequencing of codes. So when COVID-19 meets the definition of the principal diagnosis, so you're using U07.1, then that should be sequenced first, followed by the appropriate codes for associated manifestations, except in the case of obstetric patients, as indicated in this same document, and you'll find it under IC15S. There's some different direction when it comes to pregnancy, childbirth, etc. in that area. Also, if it becomes something about sepsis, you want to look at section IC 1D, D as in David for that. Okay, number 3, acute illness due to acute respiratory disease. So let's say somebody comes in for pneumonia. So for pneumonia case confirmed as due to the COVID-19, then for this, they say that you're going to assign the code U07.1 and then the J12.89 for other viral pneumonia. So the COVID, they said, would actually be assigned first as far as the descriptor. That's in the sequence. Okay, number 4, acute bronchitis. So for a patient with acute bronchitis confirmed as due to COVID-19, again, you're going to primary code will be your principal diagnosis, U07.01, and J20.8 for acute bronchitis due to other specified organisms. So now if you have bronchitis not otherwise specified due to COVID-19, then again, you would use your U07.1 as the primary, but J40 for bronchitis not specified as acute or chronic would be your secondary diagnosis. Okay, lower respiratory infection. Okay, so now we're dealing with lung action. This is number 5. If the COVID-19 is documented as being associated with lower respiratory infection, and they call it not otherwise specified, you'll see NOS, or an acute respiratory infection, NOS, U07.1 COVID, and J22 for unspecified acute lower respiratory infection should be assigned. If the COVID-19 is documented as being associated with a respiratory infection, codes U07.1 and J98.8, other specified respiratory disorders should be assigned. Okay, number 6, acute respiratory distress syndrome. So your physician will know what this is. This is typically patients that also probably suffer from asthmatic attacks or something because they have a compromised system there. So for acute respiratory distress syndrome, ARDS, due to COVID-19, assign codes U07.1 and J80, acute respiratory distress syndrome. Okay, so I know that's tough, but that's the first 6, and those are really tough to kind of get a handle on. But what about exposure? Okay, so now we're at number 7. For cases where there is a concern about possible exposure to COVID-19, but this is ruled out after evaluation, then you're going to assign the code Z03.818 and counter for observation for suspected exposure to other biological agent ruled out. For cases where there's an actual exposure to someone who is confirmed or suspected, not ruled out, to have COVID-19, and the exposed individual has either negative tests or a test result that's unknown, you're going to go back to code Z20.828. And again, that's the one that's contact with suspected exposure to other viral communicable diseases. Okay, so now we're at number 8, screening for COVID-19. So now this is a screening. This is an asymptomatic individual who are being screened for COVID and have no known exposure to the virus, and the test results are either unknown or negative. You're going to assign code Z11.59, so encounter for screening for other viral diseases. And these are for individuals who are being screened due to potential or actual exposure. Make sure you go back to the one we just talked about for exposure to COVID. The screening is pretty much for frontline workers, so because if they're asymptomatic and they don't know that they've had it or could be carriers, then they have to know if they could be exposing patients to it as well. I know a lot of people have also got a screening for this. Athletes, anybody who basically has money for the screening. You see my little bit of snarkiness there. So just know those are people who are being screened that have no exposure, asymptomatic, and it doesn't even comment if they're high risk. It just says they're being screened. Okay, number 9. Signs and symptoms without definitive diagnosis of COVID. So for patients presenting with any sign or symptoms associated with COVID, such as a fever, but a definitive diagnosis has not been established, then go back to your signs and symptoms. So for cough, it would be RO5, for shortness of breath, RO6.02, and for fever without any specificity would be R50.9. So just know that this is where you have to be very just responsible in your reporting. Now, again, if a patient with sign or symptoms has a suspected contact with someone who had COVID, this code is going to be something you're probably going to see all the time. This is the 3rd time I've mentioned it. That's that Z20.828 again for that suspected exposure to somebody. Because if you're suspected exposure and you have sign or symptoms, they're making some leaps there. And then number 10, so asymptomatic individuals who test positive for COVID-19. Okay, so for this one, they want you to assign code U07.1 COVID-19, although the individual is asymptomatic, the individual has tested positive and is considered to have the COVID-19 infection. So those are people that you're seeing probably online in videos, celebrities, whatever, that they've tested positive. They basically did a screening, and so now they're tested, and they're saying, okay, now you have that 14-day self-quarantine thing. Well, now everybody's doing that stay-at-home order, but this is a little different. They want you staying away from everybody. And so that's where they're saying you now have the infection. So hopefully that helped a little bit. Again, you can find this information on the CDC website at cdc.gov. If you are a Coding Corner membership client, all you have to do is ask and I'll send it right out to you. So make sure that you do have that information because it's directions straight from the ICD-10-CM publication and the manual that we use when we are coding. So it's really important that you do have that information. Okay, let's get to our coding question. I had a fun coding question today, actually. Well, it's fun for me. See, apparently I'm not getting out that much lately like everybody else. So this one has to do with buddy taping and fracture repair. So the question was, if the provider performed in office a closed treatment with manipulation on a patient's carpo-metacarpal dislocation of the right thumb, they also buddy taped the patient's left index and middle finger, how should I report each of these services? Because, Terry, they came in, they punched a wall, and now we have a little problem. This is one of my Arizona members. Okay, so when you're looking at this, first of all, you're going to have an E&M service, whether it's a new or established patient. That'll be somewhere from the 99201 to 205 for new, and 99212 to 215 for established. You're probably not going to hit a level 5 on this. I would say probably close to a 3 or a 4, since it's a specific situation and a problem-focused area. So on the claim, you would report 26641. That is for closed treatment of the carpometacarpal dislocation of the thumb with manipulation. And then that's for the repair, that's for the fracture care. Also add the F as in Frank 5, F5 right hand thumb modifier to the 26641 because that specifies the digit your orthopedic physician worked on. Now, the work of the buddy taping, that you're going to have to roll that in to the E&M service because there is no separate CPT code for buddy taping. So just know you may also need the 57 modifier on the actual E&M service to reflect that you evaluated the patient first, and then it was a decision for surgery because remember, these are the surgical codes is what constitutes fracture care so that you can get paid for both. So just want to make sure that you're not trying to get anything extra for that buddy taping except it's just part of the E&M service. Our coding question today was brought to you by Advanced MD, cloud software for independent medical practices that delivers industry-leading patient outcomes and financial performances. Also a leader in telemedicine modules, Advanced MD. Also, my company, Terry Fletcher Consulting, has partnered with Advanced MD and their technological advances to allow physicians and patients to maintain social distancing while continuing a plan and continuity of care with their patients. So if you're looking for a platform for telehealth, please let me know and I'll get you in touch with my contact. Okay, I wanted to end with some good news and some shout outs today. I've heard from a lot of amazing listeners that have really reached out the last few weeks. And I really appreciate that. You're all so sweet, asking me how my family's doing, how am I doing during the quarantine, and just some really nice comments. And for those of you that follow me on Instagram, Terry in SoCal, on LinkedIn, Terry Fletcher, on Twitter, Terry Coder1. So I just appreciate hearing from all of you. And also on Facebook, I have a Terry Fletcher Consulting Facebook page. So continue to find me on social media. It's always fun to hear from everybody. But let's see, who have I been hearing from lately? So hello to Ashley C, Elise M, Kat V, Anush, Sarah G, how are you doing? Sonal, Adair, Therese, and then Teresa, John P, and Lena, Rosemary, Cindy, and Rose. Thank you for my Facebook posts. And I hope I got to almost everyone the last couple weeks. So if I didn't get to you, I will definitely love to give you a shout out when I hear from you. And the good news for me is beaches just started to open here in Southern California this weekend. So not parking lots. They're saying you can't go with, a whole carload, but beaches as far as the pedestrian person can come up and walk up, and there's not going to be police basically saying if you don't get off, we're going to arrest you. So luckily that's not a problem anymore. We're slowly starting to see things open up. I've noticed that some states have started back with their elective surgeries, and so that's a good news. So we can see that the country is starting to open back up. Also, yesterday it was 90 degrees here in the Southern California area. So for those of you that have been following the Centers for Disease Control officials and things that they have posted about COVID on their website, they were saying that anything that's past 78 to 80 degrees and hotter and also humid, that weather is not a friend to COVID, and it can last only about 90 seconds, the virus itself in certain situations. But find out more about that at cdc.gov, and make sure you're not just clicking on it, that you're reading through it, so you can see that us getting warmer is going to help us flatten that curve. And I really appreciate everybody who's on the front line. I kind of put myself in the back line as healthcare administrative work, but all of you that are on the back line as well, trying to get the claims out, trying to get this right, all the struggles we've had with telehealth and understanding that process, and now trying to understand COVID-19 diagnosis sequencing and what to report. I just appreciate each and every one of you and your contribution to everything that we're trying to do here, and hopefully we're going to be opening back up really soon, and everybody can get back to work and a sense of some normalcy. I've actually been doing a couple things that have been kind of fun. I belong to this group called Podcast Brunch, and we have a virtual brunch basically, and we were on the computer on Saturday, and all of us on Zoom, and we were from all over the world, and people from Japan and Australia and Beijing and you name it. They were everywhere, and a couple people from United States. I was in California, somebody from Chicago, somebody from Pennsylvania, somebody from Jamaica, and we all get told what the listening theme is. So it was conversation, and we have 5 podcasts to listen to, and then we just kind of talk about the podcast. Did we like them? What didn't we like? What could we see change or different? And it's just great. Of course, because it's all based on time zone, I was up at 6 o'clock on Saturday. I must be crazy, but that's what it does to you when you're doing a lot of compliance with that quarantine. So I set my alarm for 5:45, got up, brushed my teeth, got some coffee, and said, "This is who I look like in the morning." And it was funny because everybody else had their hair piled on top of their head as well. But it was a good conversation. Also, one of the books I'm reading, and it's called With All Due Respect, and it's from Nikki Haley, who was our former U.S. and UN ambassador. And I'm listening to it on tape, which I prefer to read, but her voice, she's the one narrating it. It's really good. And it's actually just gives you the insight to the federal government and also the governments around the world. And it's good, it's sad, it's funny, it's just thought-provoking. But we had a virtual book club on that, and she was there. So that was also kind of a fun thing to do this week. So, there's things that you can do out there that just take your mind off what's going on around you. So, really kind of search that out. If you need help, contact me. I'll let you know what's going on out there. But there's always some things that can kind of enrich your life, enrich your intellectual stimulation, and we all need that. So hopefully everyone's doing that. Also, lastly, I just want to shout out to everyone who is listening to my Business Collective podcast. Really appreciate that. My numbers are growing. We've been around now for 5 episodes, just dropped another one yesterday, and so 1 month, and we're already at 1,000 listeners. So that's pretty exciting. It's pretty funny when you start at the beginning and you have to grow your listening population because, like I said before, now we're almost at 125,000 listeners for this Codecast. So it's been exciting to see how that grows. So thank you again to everybody, and pass it along for anybody who wants to go from employee to entrepreneur. So everyone, on this Terry Tuesday, make it a great day and a great week. I'll see you in May. Thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.